So anorectal fistulas and abscesses, that was really confusing to me when I was in residency. And so I'll try to point out the things that are testable that they'll ask you about. Mostly it'll be anatomy. They'll ask you like the boundaries of various spaces. But once you kind of figure out the anatomy, it's pretty straightforward. So a fistula and an abscess are sort of, this continuum of the same process. So the abscess represents the acute inflammatory event, whereas the fistula is that downstream sequela. So how it all starts is at the level of the dentate line. The ducts of the anal glands empty into those anal crypts. That's kind of that, design pattern that looks like that around. And they ask, like, the glands are typically submucosal, which I don't know, like, clinically why that's relevant, but that's like testable. And so what happens is one of those glands gets obstructed, and so then you develop this abscess in that area. And depending on where, and just because the glands are in that location, that's not where the abscess is. The abscess can kind of squirt out into different spaces, and that's how you define the abscess is whichever space it forms in. And so people typically have pain, they will maybe have a fever, and depending on the location, you might not have any evidence of an abscess. All you have is pain. And so we talked about when patients come to your clinic with butt pain, it's almost never hemorrhoid, so take that out. So it's almost always, it's either a fissure, it's either an abscess, anal cancer, and maybe a thrombosed external hemorrhoid. I always put that in because that's not normally what it is. So, and the tricky thing is that frequently you won't see anything. And so you go based on history, and we talked about fissures, right? Did we talk about fissures? I couldn't remember if we did or not, but that's like the topic before this. So, so you go based on history, and then you can examine them, and sometimes all you see is the tiniest little potential fissure, so you treat that first. An abscess sort of sounds a bit different in history and the quality of the pain and everything, but still, it's frustrating because you'll look at them sometimes in perfectly normal butt, and they won't tolerate a rectal exam, and even if they do, you might not feel much, but if they, anyway, so it's tricky. So here are various spaces. So this is the peritoneum here. So you'll have small bowel and a uterus flopping on here and all that stuff, and the sigmoid colon. And this is when you get like an enterocele or a cystocele, is when this lining and these muscles are weak and floppy, and this thing kind of bulges down, and you can have like any type of seal, C-E-L-E, so enterocele, or they'll call it a peritoneocele sometimes, if you're not even sure what structure, maybe the bladder, a cystocele. So anyways, this is the peritoneum, and this is the levator muscle here. And then these are the sphincters. The levator is contiguous with the external anal sphincter, and this is the internal sphincter, which you can tell is continuous with the muscular layer of the rectum. And anyways, so supralevator, duh. So if you have a supralevator abscess, you may not have any, you almost certainly wouldn't have any external ramifications of that. They just will have pain. And then you have, so that's supralevator, it's above the levators. And then you have this muscle and this muscle, so that is an intersphincteric abscess. And then you can have a perianal abscess, that's kind of right along, right close to the anus, but it's not between the muscles, it's sort of around that, you have this little sliver of the internal sphincter, external sphincter, but it's not tracking up between. And then this submucosal abscess, as you can, maybe there's a clinical connection there, correlation that since the crypts are submucosal, I don't know, whatever, maybe that would maybe help you remember it. But it's not that the majority of them are all there. They can be all over the place. And then ishiorectal, it's, you know, between the rectum and the ischium. So that's helpful. So this is what they ask you a lot about, the boundaries of various spaces. So ischioanal space. So ischioanal space here. Bloop, the ischium and the anus. So it's from the levator ani to, so that those are, this is the levator ani to the perineum. Bloop. And then the posteriorly, it's the lower border of the gluteus maximus, which you just kind of have to think about this. It's the butt cheek, you know. And medially, the levator and the external sphincter. So, ta-da, levator, external sphincter. And then obturator internus. Bloop, right there. So, there's one. And then the perianal space. It's continuous with the ischioanal fat laterally. So, ischioanal fat, perianal space. And it extends to the anal canal medially. So basically anal verge, last bit. And then the intersphincteric space, that lies between the internal and external sphincters. We already saw that. I think I took out the rest of them. So intersphincteric abscess here. And superiorly by the rectal wall and inferiorly by the perianal space. If you get confused by the like superior and inferior, they're not going to switch those up. You're just going to have to kind of know what structures are in this space. Because it's confusing, because when you're examining these patients, they're either prone or they're in lithotomy. So they're spun in all, or lateral. So, but they're doing it in the context of standing up, you know, anatomic things. And when do you examine a butt with them standing up? So just know the anatomy. And then supralevator, obviously, the superiorly is the peritoneum, laterally the pelvic wall. Superiorly the peritoneum, laterally is the pelvic wall, and medially is the rectal wall. And the postanal space, this is below the levator and above the anococcygeal ligament. So this is I couldn't get it to be nice and clear, but basically, so postanal space is back here. And so this is deep postanal space. Here's the anococcygeal ligament, so the coccyx and the anus, that's the external sphincter. Anococcygeal ligament, and the postanal space there. And, well, that will come up in a little bit. So on exam, you know, swelling, erythema and fluctuance are common, but they may not be there. And so for the treatment of an abscess, obviously you have to drain it. The book says, you know, either cruciate or an elliptical incision, don't need to pack it. And then, you know, more complex ones may require anesthesia. So one thing that it doesn't say is to go and disrupt everything like we do if you have, like, you know, an abscess in the subcutaneous fat somewhere. You like to get your finger in there, and that's what I did here. I thought, oh, I'm really good at this abscess, I'll drain. And then I get to my fellowship, and they're thinking, oh my gosh, what are you doing? Because I'm disrupting all of those pudendal nerve endings, and that will lead to incontinence. So it was one thing that I was taught here that I don't think probably from an attending, to be honest, probably from a chief, but let me dispel all of that. If you're draining a butt abscess of any sort, don't get in there and sweep it all around. You can make an incision and get pus out, and like not even gently. I mean, these are little nerve fibers. Just sort of, you can put your finger in to sort of see how far up things are and make sure there aren't any laculations, and then you're done. And that's another reason why you don't pack. Yes, Connor.
Would gluteal be an exception to that?
Is if it's anywhere where the pudendals are coming in, so you're describing a subcutaneous fat abscess. Sure, whatever. You can do whatever you want. But if it's anywhere where the pudendals innervate, don't go sweeping around, which is something I did. So sorry. So post-anal space. So if you have an abscess in the post-anal space, there's something called the Hanley procedure, and this is classically how you address the post-anal space. And this is like a horseshoe abscess. So you make counter incisions on either side of, you know, sort of posterior on either side and then and you put 2 drains up in there to get to here, because this is not a great, because it comes around, but because it's hard to get back there, and what you don't want to do is create a fistula when there isn't one. Yes.
What are your feelings on like doing these ER versus taking up all of them?
Almost. If it's a simple, and when they describe here as like a simple abscess, one like when somebody, it's their first that they've ever had, and they don't have a fistula, and it's, you know, pretty small and little discreet thing, then yeah, you can kind of take care of that, and they'll either heal or it won't, and then they'll come to colorectal clinic. And but if it's a recurrent one, or it's pretty big and there's a lot of cellulitis, or there might be they describe a lot of drainage and you see maybe a fistula there, then you know what you're dealing with, and then you have to go address the fistula.
So I guess one of the ones I was thinking of was like at Conway. I had a girl that, it was kind of what you're saying. She just showed up with pain.
Mm-hmm.
I thought that may be it, but I wasn't 100% sure. But she'd never had anything before, and I kind of just got in there just to see. And I mean, plus was rough, but she did not tolerate the like in-office procedure at all. And so that's what I was like, the right thing had been to just take her for an EUA at that point.
Yeah. Well, first you examine them as best you can. You don't have to do a DRE. What you're trying to rule out is you want to look at their butt and see if they have a fissure. If they have a fissure, and based on their history, if they have a fever and that kind of stuff, like I don't think it's a fissure. What can happen with a fissure though is that, and this is not uncommon. It's described, and it's like, oh, this is yet another one of these that we see all the time. Is that it will heal superficially, and they'll get a fissure with an abscess, which is a double whammy, but it's a superficial submucosal abscess. But based on history, if it doesn't seem like a fissure, then and you can't see anything, I would probably image them, just a CT. I would ideally get an MRI, but that's just not feasible. So a CT scan, and if there's no collection or induration or anything, then maybe like an EUA or nothing, depending on the symptoms. If I think, well, maybe it wasn't thrombosed based on an exam or something. You could go straight for an EUA. You just don't have a roadmap. But if one thing that I do is if they can tell you discreetly, it's on the right side, right here, up inside, like. Because sometimes you can press around, they're like, no, it's not so bad. Yeah, right there. Then I may not image them. I'll just go to the OR. And you can feel a fullness in the area. But it's perfectly acceptable. We go to the OR for EUAs for pain, and that's totally acceptable. And based on history and everything we have at hand, having an idea of what it might be. But I don't know. I try not to do too much in the ER, because it's pretty tender, and you never get them super comfortable. But unless it's something very discreet, and you're like, bloop. Transsphincteric. So an intersphincteric abscess. So if it's a low intersphincteric, well, here we'll start. So basically, you can open the internal sphincter along the length of the abscess and then marsupialize that for drainage. And you think like, what? But we do that all the time for like lateral internal sphincterotomies. You can divide the internal sphincter, and then it's really that external anal sphincter that you have to protect. And so for an intersphincteric, just divide the muscle and let it drain. For supralevator, it's kind of a hoopla. So if you've got to find that origin of it, meaning where the gland is that is causing this, and so but if it's and this is where it's tricky. But so if it's intersphincteric, you drain it via the rectum, and we can do that with that's why we sometimes leave a drain in through the rectum. If it's ischioanal, you can drain it through the perineal skin, and then a pelvic abscess, you just sort of find wherever you can is close by. So this is something. So a 16 or 10 to 16 French mushroom catheter. That's also what's the name of the Mallinckrodt? There we go. And you can put that in the space, rather as opposed to packing it. When they say don't pack any of these, they're describing that was for simple drainage. These are a little bit more complex, and so you don't want it to close up because some of these are up high. You know, if you're doing a transrectal drainage, that tissue heals so quickly. So you really do need to stent it open with a drain, but they can't pack that. You know, it's not, you can say, okay, put this into your rectum and find the hole, the opening, and pack that thing. So we leave that in for a couple days, and it's just hanging outside, and you pull it out. So the most ideal treatment is you find the source, the fistula, the opening into the abscess, and you put a lacrimal probe in there, and then you do a fistulotomy. You just open it up. That's not a fistulectomy where you excise the whole area. It's just you open it up, and that's the very best option. If you could do that on everybody, it would be great, but you can't, because then, you know, some of them goes through too much muscle and they'd be incontinent. Some of them, they've had several of these and they've had several procedures, and so they've already had the muscle slightly divided in a couple other places, and she's 26 years old and ready to start a family, and you're just worried about incontinence. So the disadvantage of this is that, or the hard thing is that too much inflammation, you can't find that tract. And you cannot create a false opening. I had one attending, he was such a meathead, and he'd get like frustrated, just go whack, like, well, that was helpful. You know, so now they're gonna probably have 2 fistulas. Patients will abscess will occur. Yeah, and so, you know, like if somebody with Crohn's who's gonna have more abscesses, and they're gonna have more procedures, and the abscess itself is a risk factor for developing incontinence because it hurts that delicate anatomy. And then, you know, HIV, old people, and then old and young people, because old people might have decreased tone to start out with, and then you've rendered them incontinent, and that's just so hard. Anyways, so, and then, you know, like we all know, antibiotics are not really necessary in the treatment of these. It's just drainage, unless you have an overwhelming amount of cellulitis, or, you know, they have HIV, AIDS, or they're immunocompromised because of their Crohn's. So basically, they can come back. So recurrence, if it's a non-simple abscess drainage, like the ones that we wouldn't want to do, if you just drain it, it's going to come back. Almost 90% do. And then, you know, we do fistulotomies on everybody if we didn't care about continence, but unfortunately, we have to. So that's a real issue. And this is the other thing. So that packing may heal as scarring as well, and so that impairs their continence. And just keep in mind neck fash always, whenever you're seeing these patients. And this is what's so hard, is when you're taking call from home and they describe, oh, it's this little thing, you know, you can see it when you come up in the morning, or medicine's admitting it, or it's an in-house consult. But that's the problem, is that they're setting you up for failure. Because I had one that was neck fash, and thank God I had this like little birdie in my ear saying, you should probably go see it on this Sunday in the middle of the night. And he had neck fash. He was in multi-organ failure on the floor. It was wonderful. So basically, you know, if they're immunocompromised, you know, this is one thing, because we'll get these, like concern for anorectal abscess on a patient on the neutropenia precautions floor, and surgery if you have like this obvious thing right there that you can go poke and pop, but keep all those wounds really small. Mostly you can, if they have anal pain and you're not quite sure, just treat them with antibiotics. You don't have to go and poke around and find a wound, find an abscess, unless you see something obvious. And then, so fistula and ano, we've kind of already been alluding to those topics, but we've talked about the anatomy for the abscesses, like the location of the abscess, and then here we can talk about the location of the various fistulas. So most of them are cryptoglandular in origin. Crohn's patients are not cryptoglandular, it's inflammatory. Yes?
One question before we get too far. On the last slide, these
somebody that's got lymphoma or some terrible immune system, if you look back there and they have, I remember seeing somebody, they had like a area of little tiny induration or tenderness, but we took them to the operating room and made a little stab and there's nothing there.
Antibiotics.
Just give them antibiotics. So that's why you keep the incision small.
You just keep the incision small because they can't heal it,
all.
and then
Would you even needle aspirate?
I mean you can, yeah, to tell you if it's there, but really you're only draining something that's really obvious. So if you're needle aspirating, maybe if you see redness and fullness and you're not sure where to make your incision, that's always a good thing. But if
I
you're
was just saying, if you reach the point of you are going to drain, I mean, that would be like the smallest thing you could conceivably do.
oh, I see, to get out. I mean, maybe, but you do want to be able to like open it if you can, if you're confident you can get it all out. But
Because they may have a difficult time making purulent material or collecting.
and that's why if you
abscess.
don't have pus, don't cut, because they won't form an abscess, exactly, and that's why just antibiotics, and people do pretty well on antibiotics.
Would you recommend imaging on these people first?
Unless it's obvious, yeah. You know, if they have discrete pain up inside on the left lateral wall, and then you know where you think it's maybe a supralevator, that's different because you're never going to see that. But you know, oh, it hurts right here on my perianal skin. If you don't see an abscess, just treat it with antibiotics. Okay, so again, you know, it sort of makes sense. Here's the internal anal sphincter, external anal sphincter, and the levators, and the rectal wall. And so we thought, think about them in a low and a high fistula. The lows, you pretty much can do a fistulotomy on these. So a submucosal here in relation to this internal sphincter, it hasn't gone through any sphincter, so it's submucosal, lay that open and move on with your life. Intersphincteric, this is the one they were saying you can just divide the internal sphincter up to the level of the fistula, kind of curette this out, get it all clean, and they like to marsupialize things. I don't know. So that you can do a fistulotomy on, and even some transsphincteric. So see how it's going, it involves some of this external sphincter. If it's low, if it's only involving like the distal third, by all means, you know, you can lay that open too, because you have enough. If you have 2/3 of your external sphincter remaining intact, then and what you do is you just feel, when you're doing a rectal exam, you can feel that sphincter complex and just kind of getting yourself an idea. I'll tell you, in the first part of your career, especially as a colorectal surgeon dealing with these, you're going to put a lot of cetons in, because the last thing you want to do for a benign disease is render somebody incontinent. So then you get to the high fistulas, and these, no matter what, even if you were really experienced and you were very confident that you would still treat this not with a primary fistulotomy at first. So an extrasphincteric, as you can see, it goes outside of the sphincters. It's very high. A suprasphincteric, it's just between the levator and the sphincters, and then a high transsphincteric is in that like somewhere in that more proximal 2/3. So 70% are intersphincteric. 70% of them go woo, right here. And so that's a good thing, because most of them then you can treat with a primary fistulotomy. Let's see. And then, so if you add 70 to 23, it's 93%. So most of them are these pretty straightforward transsphincteric or intersphincteric. And so like 93% of all these are those pretty manageable, cut straight forward ones. So transsphincteric, this is testable, I've seen it, originates from an ischioanal abscess. So being here in this space, right here, ischioanal space here. And so there's a tract from the internal opening through the internal and external sphincter to the ischioanal space. And so what happens, you'll go and you'll drain this abscess. Those are the ones you see a couple centimeters from the anal verge, and you drain it, and if you put a fistula probe in there, you'll find it eventually. It's not that they have a fistula on the skin. You know, it's not. They might have totally intact skin, but it's a fistula to this abscess cavity. And so what happens is if you were to pack that or drain it and then let it heal up, they would recur because they have this granulated tract to that space, and they'll recur and they'll get another abscess in the same space. That's when you just keep draining people, and then through a scar, you're draining an abscess. So these transsphincteric, and the other thing I've seen is rectovaginal fistula is a transsphincteric fistula by definition, because it's had to go through her internal and her external sphincters to get to the vagina. And these are the ones that if it's distal, then you can divide the muscle and move on. But if it's a bit higher, then you have to do something else, which is a ceton. So a suprasphincteric, it's just 5% of these. It passes above the puborectalis, and then and these can become a horseshoe abscess because they're so high. And that's when you use that Haley procedure. Curves lateral to the external sphincter and the ischioanal space to the perianal skin. So, anyways, out to here. And this is where when you get that probe, and the internal, these are so hard to find sometimes because the internal opening is down here, the abscess is over here, and you have to go up and around. And that's a hoopla. That's why those lacrimal probes are very malleable. You can bend them. And then extrasphincteric, the tract passes from the rectum above and through the puborectalis to the perianal skin via the ischioanal space. And these are, so if you see an extrasphincteric, then that's when we start thinking about funky things. We don't see them as much. So, this is basically saying how to, and so Goodsall's rule, this is very testable, you see this all the time. So this is anteriorly. If you draw a line here, so say they're laying on their back and you have them in lithotomy. If you have an abscess anterior to this line, most of the time it will go directly to the crypt opening closest to it. So here the crypt's up at the dentate line, you have an abscess, it should go. So, and this is right about 70% of the time. Sometimes we'll do this whole wackadoo thing over here. Posteriorly, it's a little bit more reliable. If you have a posterior abscess, it's most likely going to open it in the posterior midline. And I remember this in a couple ways, like which one is which. So posterior, so we always say you can do anything you want posteriorly to the sphincter complex. For some reason, the posterior sphincter right in the midline, it heals really well, and that's where it doesn't really heal well, but it's used to having fissures and everything, so functionally if you divide it, it's not that big of a deal. And so I don't know why that helps. It's just the posterior midline is very relevant surgically as far as surgical anatomy goes. The other thing I think, something that's weird to me is that, does that mean that these crypts just don't make abscesses, That's one thing that always never really made sense to me, but I guess they don't. I don't know, according to Goodsall's rule. And the posterior one is a little bit more reliable. So, anyways, so that's that. And that's very testable. Investigations, anoscopy, you still, just put a Hill-Ferguson in and some lacrimal probes, and that's generally the best thing. You can do fistulography. I've never done a plain old fistulography with contrast. We do all the time. I'll inject like hydrogen peroxide into the abscess cavity, or I do my own kind of thing where I just press on the abscess and I watch where the pus comes out. So instead of hydrogen peroxide, so I don't ever drain the abscess. You always want to keep pressing on it while they're prepping, it's coming out. Well, then you've lost all that. So I don't touch it, and we put the retractor in, and then you press on the abscess, and it'll help you see where the opening is. And you use Goodsall's rule to figure out where you want to start putting your retractor at first. So if it's posterior to the line, you just put the retractor straight up and down so you can see posterior midline, and you press over here and it goes boop, and then you say, okay, good, I have my opening, I know it's there. It makes you feel really good when you know there's an opening, because you know that when you're sitting there probing for 15 minutes, you're actually probing for something that exists. If if you're not sure they have an opening because you pressed all over and you never saw any like pus coming out, that's like, I might be looking for something that is closed up or who knows. So CT scan, like you can distinguish an abscess from cellulitis or pain and that kind of stuff. Endoluminal ultrasound, we never really used this for, we used ultrasound a lot, but not for benign disease like this. But you just know that you can use it as an adjunct. Use it with hydrogen peroxide as an adjunct, and because you can see the bubbles on ultrasound, and that might be helpful. We did use MRI, so people who kept recurring and had already had a couple EUAs and you couldn't find any tracks. And we did have an endoanal coil. I honestly don't know if they have one here, but that gives you better sensitivity. Anyway, so basically you want to get rid of the fistula, stop it from recurring, and preserve function. And instead of using hydrogen peroxide, sometimes you can use methylene blue. They use milk here in the book. I thought that was funny. I'll take the sterile milk, please.
This is 2%.
Yeah. And so you can look at the, basically it's just examine it, and you can use contrast or something to help you see it. And so fistulotomy, that's the best if you can do it. This is a horrible picture, but basically that's the probe in there through, and you can open that up. Moving on, look at that. So aceton is just a, this says any foreign substance that can be inserted into the fistula tract to encircle the sphincter muscles. So we typically use vessel loops because they're soft, they're durable, they are smooth, so they don't have a bunch of grooves like a braided suture does. But some people will use a silk. One thing, and there's a cutting and a draining. Nowadays, very few people actually use a cutting aceton. But one thing I did see, they kind of talked about it as a historic procedure, and I thought this was really smart. What they would do, and they used to do them 30 years ago, is they would put like 6 silks through, all like a big bundle of silks, and then only tie one down tightly, and the other ones would be loose, and then have them come to clinic and cut that tight one and tie another one down a little bit tighter. So they're all there, the ones that you're going to use, and you just slowly. So the principle of this is that if there's too much muscle involved, and if you with the fistula is like a high transsphincteric or a suprasphincteric, and you just can't go whack through it all, or else they'd be incontinent, then what you can do is put aceton through it and slowly divide. You divide on your own, in the OR up to the sphincter complex. So it's already gone through the skin and all that stuff. And then you just slowly, over the course of 2 months or so, tie it down a little bit tighter, a little bit tighter, a little bit tighter, and it heals behind. Some people say it's like cutting ice with a string. Like the string's not hot, it's not cutting through, it's just slowly going and it's freezing behind it. And that's the point of this. It's very painful. Like people aren't comfortable, for 2 months. So we don't do that very much, but that is a cool technique, I thought. So a draining aceton, this is the same thing, you just don't make it tight. So it's just there, and it doesn't hurt them. Some people have these their whole life because they're sick of, they've had so many of these problems. And that, they shouldn't have it their whole life, but some fistulas are just a total nuisance. And so what this does is it keeps it draining, so you're not going to recur this abscess. You've got the fistula tract identified, and it's laid open, and it's going to keep the abscess open, so it's never going to recur and give them a painful abscess. So they're happy, good, check. And then you just give it time, and it will fibrose along that tract, and then that's when we go and we do some of these other procedures that we're talking about. And you can leave this in for months. And so basically you do this when you don't want to make them incontinent. Blah, blah, blah. So here's a picture of it. So here you go and you drain this abscess, find this transsphincteric fistula, and put a aceton. So once you've got that all fibrosed, this tract, you have a couple options. you can do an anorectal advancement flap, and this is where you raise up a flap, and it's full thickness, so it's mucosa, submucosa, and some of that internal sphincter. And one of the keys is that it needs to be triangularly shaped with the point pointing out, because you need to have lots of blood supply. So it's basically a 2-to-1 ratio. So if you need to, so you open it up and you find that tract distally out here, and you elevate, and it gets very difficult to tell what's what when you get to that internal opening. But you kind of buzz, making sure you're not getting too shallow. You really don't want to be shallow. But the tricky thing is, posteriorly and laterally, like, who cares? With abandon, do whatever you want. But anteriorly, you'll get into the urethra or you'll get into the vagina. And so it's kind of harrowing. So lots of feeling, and you don't want to burn the vagina, even though, anyway, so that can be stressful. So, but you raise this flap and then you bring it down, and you want a whole 1 centimeter of tissue that will beyond the area of that internal opening, and then you suture it in place. I've done these, and I don't even know what this picture is showing, but down here I thought it was helpful. It's not really a straightforward intrarenal advancement flap, but basically you can see here is the internal opening. They've elevated a full thickness flap, and they're bringing it down, and they're going to suture it right here. And the internal opening might have been like right here, so you're well beyond a centimeter of good healthy tissue, and it's a good thick pedicle. So there's that. Fistulectomy, you'll read about that. I actually did a couple of these in my fellowship. Is you take out a wackadoo to healthy tissue, just to remove that whole bit. You're sick of it, you're frustrated, and this is like on a healthy dude with a big muscle that's bulky and healthy, and then you sew that together. And we did that. But the problem with that, as you can imagine, is you've left them with a big defect, and you sew it together, and what if that breaks down? But they did great. They were so confident. That's something you do when you've done like a bunch of these and you haven't had 1,000 incontinent patients, and then you're like, let's try this. And then fibrin glue, you basically, when you find your internal and external openings, you can clean it all up with a curette, and then you inject from the outside, or you put the probe up inside and you inject fibrin glue as you come out. They say, yeah, it really doesn't work. People don't do this very much. Yeah, okay, yeah, these great 70-80% success rates. Well, that's normal. Like, you drain an abscess, it doesn't come right back. But over long term, like 6 months, only 14% were successfully addressed. So, but that is something to know about. And a Fistula Plug, we do use these. So you leave that ceton in, and then once everything is kind of cooled down, there's no infection, everything's nice and clean, like a, because the anus is known for being clean. Then you go up, and this is the device, and it's pretty cool. You pull it all the way out here, and you snip it here at the skin, and then you sew it, taking really good bites. You want to get good bites of the muscular layer to hold this in place. And it's an absorbable suture. And so you leave that in place, and it's absorbable, and in theory, depending on where you are, they have better, apparently in Vermont, they have great results with this. Everybody laughs about how, well, the Vermont anus must be very different from everybody else's. But I don't know, in my year, we seem to have good results. So those are some options. There's also a lift procedure, which is ligation of the internal fistula tract. And that's basically doing you raise a flap like you do for the advancement flap, and then you identify the fistula, you get to it and you dissect it, and then you tie it off with an absorbable suture on the outer, like in that intersphincteric groove. So this is an intersphincteric dissection. And then you tie it on the external side. And you really can tie it on both sides, sure, whatever. And that is in theory going to close it off. People have had varying results with it, but what it has done and what everybody says, the advantage of this and why people are starting to really use it is even if the fistula recurs, it's going to recur as an intersphincteric as opposed to a transsphincteric, and then you can just divide the muscle. So, anyways, pilonidal disease, basically, there's no good surgery for it. Mostly men. Let's see. It is, insurance companies will pay for laser hair removal in people with recurrent pilonidal disease. And just know that pilonidal cyst is sort of a misnomer. I need to be done, don't I? Let's see. I think pruritus ani. I'll send you these slides. The pruritus, I don't know. I've never had a question on the abscite about pruritus. I don't know. Have you guys? No, I haven't either. But if you do, we'll talk about it. Okay, there you go. Benign anorectal disease.